G'day, welcome back. Today we're going to be talking about the breast ultrasound. It's a very intimate scan that's very emotionally, physically and mentally challenging.
They come in all wonderful shapes and sizes. Some people only have one breast, some people have no breasts. We scan men's breasts and we scan women's breasts. So let's go, Katrina.
All right, let's do it.
We're off. You look lovely. Love your necklace.
Oh, thank you. So with the breast ultrasound, people present for many different reasons. Men and women present for breast ultrasounds. From very early ages to late into their 90s, we can see people for this type of scan. More than likely, we have people presenting because they've felt a lump. Lump can be tender, it can be something that occurred overnight, it can be something that's been there for years. People present with pain, they present with symptoms of mastitis during breastfeeding. Maybe they've had an accident and they've knocked the breast, they have implants and they think that they might be ruptured. Things are changing, size is changing, there's discharge from the nipples. People also can present with just for a checkup. They've had breast cancer in the past, they have a family history of breast cancer. There may be people that will also present and they have breast cancer. So they know they have breast cancer and we're just following the progression of the area, whether it be a lump or a nondescript area. At this point, it's really important to know that people are going to take different pathways of treatment. It's not always going to be the conventional lumpectomy, mastectomy, chemotherapy, radiation, and then that's it. People may take different ways. In this case, we are here just to listen and to do the best that we can in the situation that we're in and give them our best attention.
So your patient for your breast ultrasound is usually thinking the worst, especially if they can feel a lump. So you've just got to give them that extra little bit of personal care and just show that you understand they're anxious, but explain the whole procedure that you're going to do. Tell them that you're going to be taking quite a few images and that if you stop and measure things, it's not that you're freaking out about something, it just means you're getting landmarks from the nipple. Because I've often found that if you don't explain that, your patient panics every time the beep on the machine goes, or if you start frowning or getting a ruler out or in a particular area for a long period of time. Just try and let them know before you start scanning that you're going to be starting all the way round and you're going to be looking up high into the axilla and all around the breast. So again, it comes down to a good explanation.
Communication is very important, I think, here.
Yeah.
Just giving them that little bit of extra information about what we're going to be doing. It definitely calms people down and it lets them know that that you care and that we're here just to look after them.
Yeah, just that extra little bit of personal attention is great. I personally have the patient lie on a pillow just to lift their breast, the side that you're scanning up a little bit higher to try and get a level playing field, as I call it. Some people might use a wedge. So you'll get your own idea of how to position the patient that's comfortable for you and for them.
Definitely. Everyone does it differently and you have to be aware of what cushion you're using. Are you still able to get close enough to the patient so you're not reaching further away because there's a cushion there pushing you away? These are all things that it's trial and error half of the time to see what actually works for you, and so you don't end up leaving the end of the examination and your arm's about to fall off.
Yeah, and I often sort of use a little pillow that I rest my arm on the patient. Just say, look, I'm going to be resting my arm on you, or I'm going to be leaning over the top of you. It's quite a close examination for both of you. So they'll be fine once you tell them that's what you're going to do.
Just be wary of what you eat for lunch before you scan people. Avoid garlic,
onions,
salmon.
Okay. Like everything in ultrasound, clinical history is imperative. You've got to make sure that you find out as much as you can about the patient's prior breast imaging. If they've had scanning elsewhere, try and get hold of the report, because that's going to be really important for the radiologist to do a comparative. But what you've got to do first is find out whether they've got any particular areas of concern, if they've got any lumps that they're worried about. And clinically, it's good for you to feel those lumps as well, so you can hone in exactly where the patient's targeted area of interest is. Find out if there's any family history, whether it's on the paternal side or the maternal side. If it's their mother or grandmother or a sister, find out whether they had breast cancer premenopausal or postmenopausal, because all those bits of information help the radiologist in their reporting. Find out a little bit about the patient's menstrual cycle. If they get pain in their breasts, find out whether it's just when they're ovulating or when they've actually got their period. Find out if they're on HRT or on the pill. All those little bits of information that you gather gives us a much better overall idea of their health and situation. I'm going to do a quick drawing, badly of course, of a breast. So, oh no, this is awful, Katrina. That's not going to work.
That looks like a tree stump.
Take 2, breast drawing. They don't employ me for my drawing, Katrina, so
Thankfully.
Thankfully.
Mm-hmm.
So we all scan a breast quite differently. You'll get your own way of doing it, one that suits you. All you've got to do is make sure that you cover the whole breast, including right up the top here, just under their clavicle, because some parts of that breast aren't seen on a mammogram. So make sure you look up there and make sure you scan into the axilla and the axillary tail. So when I scan, I do quadrants. Other people scan radially. You'll get your own way of scanning as long as you're confident you've seen the whole of the breast. And don't forget to scan the nipple. You have to angle under the nipple and from either side of the nipple to make sure you can see, because the nipple itself shadows and causes artifacts. But then you've got to record it all the way around, and you're recording radial scans at all the o'clocks. I think that probably covers it, Katrina. Is that right?
It's beautiful, Linda.
Thank you.
Thank you for your help.
So if your breast ultrasound is in combination with a mammogram, always do the mammogram first, unless they're in our department, got implants or under 35, and then we would do the ultrasound first. But do the mammogram first and then chat to your mammographer. Do a good handover with your mammographer. They will let you know about any particular areas of concern that the patient's told them about, and check with your radiologist in case there's a targeted lesion that they want you to find with ultrasound. Okay, right, hold it. Okay, this is terrible. Katrina wanted to lie down like Cleopatra, so she's having a go at that. So thanks for listening to us. Don't forget to push the subscribe button if you want to catch a little bit
Push
more,
the subscribe button.
a little bit more of us. So take care of your patients. Bye.
Bye.
So patients are obviously